and welcome to the FDA Oncology Center of Excellence public panel discussion known as Conversations on Cancer. And today we are thrilled to bring you the very first day of the second annual National Black Family Cancer Awareness Week Conversation on Cancer with our hashtag BlackFamCan. So we're encouraging you to participate on social media as well throughout the week. Today is the initial day, the 16th, but we run through the 22nd, and we will be looking for your tweets and your Instagrams and your Facebook posts. And what am I missing? TikTok, whatever else is out there, Facebook. Please do communicate with others about the importance of having awareness for Black families in regards to cancer, and use the hashtag BlackFamCan, please. We have a really interesting group of participants for today's public panel discussion, and we do want to make sure to let you know that this opportunity loops in with the work of the Cancer Moonshot 2.0, which established goals to reduce cancer death rates by at least 50% over the next 25 years, and to improve the experience of living with and surviving cancer. We're rather global in our approach. We also want to make sure that people get caught up on their screenings that they may have missed during the pandemic, since so many of us were unable to actually keep those appointments. So it's an opportunity to talk with family, friends, anyone you know, to make sure that awareness is the name of the game and that you influence the people who are in your sphere, particularly by engaging the generations and speaking with those who may have a familial cancer history and have not talked with family members about it. It's important that we talk to each other and communicate. It's emphatic, in fact. I have said plenty without saying my name. I'm Rhea Blakey. I'm the Associate Director for External Outreach and Engagement at the FDA Oncology Center of Excellence. And again, I welcome you. And I also would like to introduce Dr. Richard Pastor, who is the Center Director here at the Oncology Center of Excellence, who really was the person who posed the question, does such a thing exist? Where is National Black Family Cancer Awareness Week? Rhea, he said. Hey, Rick.
Okay, thank you, Rhea. It's a pleasure to welcome you all to this second event. And I just want to reiterate a lot of what Rhea mentioned, and the importance of family really in interacting together to bring awareness to issues of cancer detection and cancer treatment. And I can't emphasize more our commitment to this activity. Rhea also mentioned the Moonshot program, and I have to emphasize that our organization, the Oncology Center of Excellence, was really born out of the first Moonshot endeavor nearly 5 years ago. So we share something with basically the Moonshot program and owe our existence really to then Vice President Joe Biden and his initiative in launching the first Moonshot program. And obviously, we're very active in the Moonshot 2.0. Here again, I just like to emphasize our commitment to diversity in clinical trials, diversity in the administration of medicines and the practice of medicine. And really, this has been one of the cornerstones of the Oncology Center of Excellence. So again, welcome to this second event, okay? And we look forward to interacting with you, not only during this week, but really throughout the entire year.
Thank you, appreciate it. So we're gonna ask our panelists to self-introduce very briefly. We'll start with Reverend Leroy Miles, but we have also agreed that we'll go by first names after this. So, don't think that we're not being respectful of others. We've all agreed. So Reverend Miles.
No, not at all. Not at all. My first name is not Reverend, so that's for sure. So Leroy Miles here in sunny Philadelphia. So happy to be part of the panel. And I hope what we bring to this conversation is, as a person of faith and representing faith tradition, just really being involved in clinical trials, the importance of understanding social determinants of health, health disparities, and being purposeful around early detection of screenings. And so that's something we've worked on for a long time. And it's so wonderful to be part of this conversation again. So we thank you and looking forward to the dialogue.
Thank you. Dr. Stephen Noble.
Good afternoon, everybody. My name is Stephen Oval. I'm a thoracic surgeon here in Chesapeake, Virginia at Chesapeake Regional Healthcare. I'm the medical director for the lung nodule clinic, really looking at screening for early lung cancer detection. Also a author of a children's book, The Heart of the Hero, the story of Dr. Daniel Hale Williams, looking to encourage the next generation of young Black medical professionals and just really any individual to really aspire to their dreams. And I serve as lead medical advisor for Live Share Health, a healthcare organization looking to leverage community places of trust and safety in an effort to really address healthcare disparities, in particular in the Black communities, but in other communities of color. And as lung cancer being the #1 cause of cancer death in America, really excited to be here today and talk about all the treatments and or really screening for lung cancer. So thank you.
Thank you. Dr. Edith Perez, welcome.
Hello. It is my pleasure to be part of this panel, and I'm a woman who wears many hats. I'm a Chief Medical Officer of Bolt Biotherapeutics and Professor of Medicine at Mayo Clinic. But today I'm actually here representing Stand Up to Cancer as the chair of the Stand Up to Cancer Health Equity Committee. And I truly look forward to having an opportunity of discussing the activities that we've embarked on at Stand Up to Cancer, and also announce an exciting opportunity for a new grant that we hope that we'll receive many applicants for, as it will address, the removal of barriers to clinical trial participation in underserved populations.
Excellent. Let's see, Calais Prince is also joining us. Hi.
Yes. Good afternoon, everyone, and thank you so much for this opportunity to participate in this conversation. I'm Calais Prince, Associate Director of Science and Health Policy at the American Association for Cancer Research. And in my role, I'm able to combine my professional background as a cell biologist that's striving for cancer health equity with my personal experiences in navigating and caring for family members with cancer, as well as overcoming the hardships associated with being raised in medically underserved communities. And so, again, I'm very appreciative of being here today, and I look forward to describing a lot of the efforts coming out of AACR to addressing cancer health disparities and encouraging health equity.
And including the most recent report. So we look forward to that as well. Yeah, yeah. Stephanie Walker was recently in Chicago at ASCO and had a poster that was extremely well received there from the patient perspective. Hi, Stephanie.
Hi, how's everyone? Thank you for this opportunity. I happen to be the patient on this little panel of great people here. I am a patient diagnosed with metastatic breast cancer in 2015, de novo, no history of breast cancer, living my life as a nurse. I did a poster, as Rhea said, at ASCO, and it was called the Become Project, which is the Black experience in clinical trials and meeting opportunities for meaningful engagement. And that poster was basically done by survey. The results were done. And it was basically about Black men and women with metastatic breast cancer in clinical trials. And there's 4 points later that I'll talk about, and also with some action points. Don't do anything without follow-up.
Excellent. And I'm going to encourage all the panelists to think about your action items that you want to send this audience away with, takeaway messages and so forth, because this is a great opportunity. And I know somebody who already has his prepared, because he always does, is Dr. Kareem Watson, who is with the NIH All of Us Research Program. Hi, Kareem.
Hi, Rhea. Thank you all so much. As Rhea said, my name is Kareem Watson. I'm the Chief Engagement Officer for the NIH All of Us Research Program, but I'm here today also as a trained cancer disparities researcher. Prior to joining the NIH, I spent 16 years at the University of Illinois, Chicago in academia conducting cancer disparities research, primarily looking at cancer prevention and control for colorectal, breast, prostate, and cervical cancer, and as well as lung cancer. But I'm also here as the son of losing both my parents to complications from cancer. Most recently, my mother from lung cancer, and then last year, my oldest brother, from complications from colorectal cancer. So I'm very fortunate to be blessed to be able to use the platforms that I have to address cancer disparities, and I'm excited to continue to partner with Rhea and the team to bring this issue continue to bring this issue to light. So thank you.
Well, again, thank you to all of you. It's important that you're here because influence can come in many shapes and forms. However, this opportunity, I think, is one that our audience truly appreciates because it is a public forum. It is an opportunity for people in the public to see some of the work that's going on, not only at OCE in regards to National Black Family Cancer Awareness Week, but more importantly, the broader ecosystem of opportunities that we all have to decrease cancer disparities and increase cancer equity. So with that, we have a special guest welcome from our Commissioner of the Food and Drug Administration. Please stay tuned and listen for Dr. Robert Califf.
I'm delighted to welcome the panelists and all of you who are viewing today's conversation on cancer, hosted by the FDA's Oncology Center of Excellence, or OCE. Today marks the start of the second annual National Black Family Cancer Awareness Week initiative, which was created by OCE's project community. National Black Family Cancer Awareness Week was initiated after a conversation between Dr. Rick Pastor and the OCE's Rhea Blakey. It was designed to fill a gap in health education and healthcare, and it's an example of how simple creative thinking can affect real change in the work we do and in public health. African Americans have a disproportionate cancer burden, including the highest mortality and the lowest survival rate of any racial or ethnic group for most cancers. Black women, for example, are 41% more likely to die from breast cancer than white women, despite lower incidence of the disease. According to the American Cancer Society, there are expected to be nearly 225,000 new cancer cases and nearly 74,000 cancer deaths among Black people this year. While research has shown that a small fraction of the variation in cancer mortality can be attributed to genetic differences, the majority of the Black-white disparity is due to variations in what has been called the social determinants of health, wealth, education, and access to care, all resulting from centuries of structural racism. For example, one notorious form of historical societal discrimination, known as redlining, involved denying loans to creditworthy applicants who lived in predominantly Black neighborhoods. This practice created an obstacle to upward mobility for those who lived in these communities. Research has shown that areas with a history of redlining are associated with increased health risks, including later stage cancer diagnosis. One study found that redline neighborhoods have 60% higher breast cancer mortality compared with other neighborhoods. While we don't know all the reasons for this correlation, its existence is part of the reason for this initiative, to help ensure awareness of what this racism left behind so that we can work to address and correct it. The launch of National Black Family Cancer Awareness Week coincides with several other important actions initiated last year, including the signing of the Presidential Executive Order advancing racial equity and support for underserved communities through the federal government, the 50th anniversary of the National Cancer Act, and President Biden signing the Juneteenth federal holiday into law, which appropriately occurred last year on the very first day of this inaugural National Black Family Cancer Awareness Week. At the FDA, we're focused on striving to achieve equity in the treatment, diagnosis, and prevention of cancer. For instance, we've worked hard to strengthen the clinical trial process and make it more inclusive. Historically, there has been underrepresentation of African Americans and other minority participants in clinical trials. Changing this is important not just to alleviate discrimination, but to improve health. Certain groups of patients, whether based on their race, sex, or other differences, may respond differently to therapies. So to develop effective treatments, it's critical that the data obtained relates specifically to the individuals to be treated. We also know that particularly in oncology, access to new treatments is closely tied to clinical trial participation. Similarly, an important part of the FDA's efforts to reduce tobacco-related death and disease involves ending discrepancies and disparities that relate to race. For instance, we recently issued proposed new product standards for certain tobacco products to prohibit menthol as a characterizing flavor in cigarettes. These standards will not only help reduce tobacco-related deaths and disease, but also will help advance health equity. That's because data show that of the more than 18.5 million current menthol cigarette smokers, ages 12 and older in the US, there are particularly high rates of use by African Americans, among others. Another important activity that Project Community and the FDA is encouraging for all National Black Family Cancer Awareness Week participants is to engage the generations. This means talking with family members about familial cancer history. I hope that you will do this now, during this week, and in your Juneteenth gatherings. But don't stop there. It's something that, if continued throughout your lifetimes, will help reduce the burden of disease in your families. There are other important activities you can do quickly and easily. In February, President and Mrs. Biden announced a call to action on cancer screening to jumpstart progress on the nearly 10 million screenings that were missed as a result of the pandemic. Our goal is for everyone in the U.S. to benefit equally from the tools we now have to prevent, detect, and diagnose cancer. So get screened and encourage your friends and family to get screened as well. Working together in all these different ways, we can make a real difference. Today's public panel discussion is a continuation of these and other efforts to reduce cancer disparity and increase equity while addressing the Cancer Moonshot goals. So thank you for your engagement on this issue and your participation today.
And just a quick recap. Thank you, Commissioner. Greatly appreciate your comments. We know you're very busy these days. But for our panelists, the Commissioner mentioned the nearly 75,000 expected cancer deaths among African Americans this year, according to the American Cancer Society. But I thought particularly interesting was his reference to social determinants of health, and specifically redlining and cancer cases, breast cancer in particular. And so, this is an institutional aspect of disparity that African Americans have really lived under for many, many, many years. And I think that it is important that an organization like the Food and Drug Administration appreciates the historical societal discrimination. However, what we also want to do is to move the dial forward. So with that, Kareem, if you don't mind me starting with you, because I know that it's near and dear to your heart because of your life experience in particular. How do you see in your work the importance of these social determinants of health, how one's zip code really does impact their propensity to have to deal with a cancer diagnosis?
Thank you so much for that, Rhea. That question, and I was so excited to see that the Commissioner talked about that in their presentation to mention the importance of redlining. I was recently looking at some data, like I said before, prior to joining the NIH, I was a cancer disparities researcher, and I'm located in the Chicagoland area, and I'm still here. And one of the things we know in Chicago and across many urban cities across the U.S., that your zip code can be more important than your genetic code. One of my mentors, Dr. Robert Wing, calls it your ZNA. And in Chicago, there's a study done by Virginia Woolf Common University that showed that just by one train stop in the Chicagoland area, your life expectancy can decrease by more than 20 years. That's one train stop to determine life expectancy. That shouldn't be the case. We also know in the cancer space that many times the environment in which that you live, from the air you breathe, from even the stresses that you may be under. I once was with a particular patient population and they were encouraged to get out and walk. I had to tell that researcher that was telling those patients to get out and walk, that they had to be mindful of the environment that people live in, that sometimes going out, making a recommendation to simply go out and walk is not an option because of the environment of the neighborhood that you live in and the stresses that you experience. And so it's so important. And the last thing I'll say, one of the studies that I was working on prior to joining the NIH was a study we called RECODE. We're looking at the impact of lung cancer, elevated risk of lung cancer in African-American men. And it was an epigenetic study, meaning that we were not just looking at the genes in which people were born with, their DNA, but we were also looking at the ZNA. We're looking at how stress impacted those men's risk for lung cancer, how stress could even impact men that smoke, how the way the dangers of impact of smoking can even be changed and impacted by the stress you're under in the environment that you live in. So this concept of ZNA is so important. And we've been really fortunate in the All of Us research program to also address this. So in addition to collecting information about participants' genome and other family history information, we've collected information about social determinants of health as well. So it's vitally important, really.
Stephanie, I'm going to ask you maybe to talk a little bit about your experience. You'd mentioned in your introduction that you're currently a patient, but also you have a background as an RN. And I'm wondering, A, were you asked if you wanted to participate in any clinical trials? And I think I know the answer to that. And that's something I sort of want the panel to drill down on a little bit more about, asking and making sure that we're communicating effectively when it comes to patients. but then also any kind of support you may have received or not.
No, it's funny that you asked because I was diagnosed in 2015 with metastatic breast cancer, but didn't really know too much about advocating for myself as a patient until 2018, so 3 years in between. And I had to learn to navigate the system of trying to get financial assistance, social worker, dietary, mental health, spiritual counseling, all of that I had to navigate on my own. I didn't realize that everybody should have, quote unquote, or had the opportunity to have one. I was told that I didn't really, quote unquote, need one because I was a nurse and, I knew it all. But that's different navigating your own healthcare in the setting of metastatic breast cancer, as opposed to me navigating or advocating for my pediatric patient in a critical care area or my hospice patient at the end of the life. So hence that, I don't know if this is where you want me to talk about the project that I did, but
yeah, please.
I did a poster presentation at ASCO, and it was about Black men and women with metastatic breast cancer in clinical trials. And the big thing that we found out, and it kind of shocked me that it was just simple. The number one thing was ask, inform. We are not asked about clinical trials. I was a nurse. And then even then, thinking about clinical trials, I always thought that was something that you always utilize at the end, not you could utilize it in between, at the beginning, any kind of things regarding clinical trials. The Tylenol that you take went through a clinical trial. So hence here we are. That was the number one thing. Healthcare professionals are not asking us. They're not inspiring trust with us. Yeah, we all go back to the history of where trust was a big issue, but it's here. We need to build on it and go forward. So we still need to have trust in our communities. And that's done by having people to come in that have, that look like us, that have the same lived experiences as us in our community. You have to ensure access. You have to make sure that we have access to those clinical trials. Don't tell me where to go find that clinical trial. Wonder if I don't have the computer experience to use a computer to find one, or I don't have internet to find one. So not only tell me where to get those clinical trials, having the access to do it, the logistics to go to the clinical trial site. If I can't fly to California from the East Coast every 2 to 3 weeks, maybe you can bring that clinical trial to my house or to my area or to my community cancer center that 80% of the patients go to anyway, and also address our concerns. When we come to you with these concerns, they're legit concerns. Address those concerns, especially those about side effects. Just because it wasn't, quote unquote, listed in that clinical trial as a side effect doesn't mean that medicine was made. As someone mentioned, the genetics of our makeup may not have been kosher with that medication, and it's going to show something different with us. Our action plan for Become, because I believe if I'm going to put it out there and tell you what is wrong, then we need to come together as a group to fix it. And one of the first steps we wanted to do is expand the survey respondent to represent the general base of the patient. I did this online. I did it through social media, emails, through the Alliance, Metastatic Breast Cancer Alliance, their email outlets, did it, wherever I could get a survey to, but I got the choir. I didn't get into the community where I wanted to get, but I have to understand this whole project took place during the pandemic. It was all done online. Everybody communicated online. We didn't meet each other until ASCO. So, for me to get that far on just that, it was a task. Also share results. We're trying to come together and put down a symposium together in the fall to talk to healthcare providers, how to talk to us. How to understand what we are going through. Just because we show up in your office and we're looking happy and cheerful today, don't mean that's not, I'm going home to that hotel room or that room where I'm taking care of 3 generations of family members, got to get the kids off the bus, again, don't have anything to eat. Those, you need to know where I'm going after I leave your office.
Yeah,
and
life
also,
goes on.
My goal is to increase the clinical Black patient enrollment in clinical trials. We had the dismal response. There's only 15% of the patients with cancer are Black, but only 4 to 6 of them are participating in clinical trials. We need to up those numbers.
Well, you have said a mouthful. However, there's always more to be said. And given that, Kelly, I'm going to ask you to maybe give us a synopsis of this latest health disparities report from AACR.
Sure thing. And this is like wonderful timing considering all the points that have been mentioned so far. And so like a quick and dirty overview of this report. It's a comprehensive examination of the progress that we've made to reduce cancer health disparities over time. And so, of course, we discuss, that disparities they exist and the difference in your racial and ethnic status and where you live and whether or not you're a medically underserved member of a population can definitely have an impact on your treatment and your outcomes. And so the importance of also detailing factors that can contribute to these cancer health disparities, including adverse social determinants of health, providing context for how cancer develops and the importance of identifying genetic risk factors, which can vary, again, based on your ancestral background, examining the disparities that exist in preventable cancer risk factors and screening for breast, cervical, colorectal, lung, and prostate cancer, and describing the disparities that exist in clinical research participation and in cancer treatment. And so similar to what Stephanie's mentioned and what everyone has mentioned so far, how where you come from can have an impact on your treatment and your outcomes. And even if there are these good intentions to have appropriate care, but if I'm in an area where I don't have access to healthy food, if I don't have safe transportation, if I am underinsured, these things are compounded, and more times than not, historically underrepresented minorities are impacted by these. But we also conclude by describing future paths forward. So, increasing diversity in cancer care and research, which Stephanie again touched on, the importance of having someone that looks like you, that can relate to your concerns, that can hear your voice, and a lot of times translate in a way that you can receive the message. And then supporting evidence-based policies in coordination and supporting researcher programs in the federal government. And so ideally, it's a call to collaborate in addressing the multiple factors that can have an impact on cancer outcomes. And so, I look forward to the continued conversation. This amazing panel. And
So, Stephen, I'm going to ask you, because I know you represent a number of different areas. You are a graduate of a historically Black college and/or university. You are a physician who works with patients who unfortunately have been diagnosed with cancer, but you're also very proactive in dealing with matters of health issues on the very real community level. So talk a little bit about what you've heard thus far and what you hope will happen following this National Black Family Cancer Awareness Week. Where do you see us going?
Thank you, Rhea. I echo some of the sentiments that have already been mentioned, harkening back to the discussion about redlining and social determinants of health, in particular with lung cancer, again, the number one cancer killer of Americans. When we look at lung cancer, we see that the mentholated cigarettes, and the impact of mentholated cigarettes in Black Americans and how they've been marketed to Black Americans. And so when you go to certain zip codes, you may find, the advertisement for mentholated cigarettes being more prevalent in the inner city or in Black populations. And you find that 85% of men that smoke actually smoke mentholated cigarettes in comparison to their white counterparts. Why is that important? Because mentholated cigarettes are more addictive. And so to that point, the FDA is actually looking at banning mentholated cigarettes. And so that is something that I think that as a community, we need to support as well as encourage individuals to stop smoking. There was a Canadian study that felt that if the United States banned mentholated cigarettes, it could lead to almost 1 million smokers, including 230,000 African Americans, to be able to quit smoking within the first 13 to 17 months. So basically within a year and a half, you'd have that number of individuals no longer smoking again if you simply just ban mentholated cigarettes. So as far as the community, when you look at these social determinants of health, that to me is one of the biggest impacts, mentholated cigarettes in the Black community. Second, as Stephanie had mentioned, We need more providers that look like us. And to that point, the importance of HBCUs, the importance of school to medicine pipelines, counteracting those school to prison pipelines. One of the reasons why I wrote the children's book was really to encourage that next generation of physicians, because as much as we need to have more Black providers, what we find is that there's about 2% of all physicians are Black men. And if you're a Black man that may have prostate cancer, lung cancer, you're going to want to talk about those sensitive issues to someone that may look like you. And studies have shown that there's, when you have congruence, racial congruence between patient and provider, the care improves. And I think the third thing to touch on is really the importance of community, especially community leaders, community pillars, churches, barbershops, hair salons. So working with Live Chair Health, a healthcare organization looking to really decrease healthcare disparities, we go into community hubs, we go into churches, barbershops, hair salons, stores to really bring access to the people that need it the most, those that are on Medicaid, those in communities that are hard hit. And it's been mentioned before, it's difficult as a provider to tell people to go outside and run when, you know, that may lead to certain situations. Rest in peace, Ahmed Aubrey. When you tell people to go to the grocery store.
Oh, I think we lost your audio. I don't know. Oh, unfortunately, we did, Stephen. With that, I'm going to go ahead and skip for the moment to Reverend Leroy Miles, who has done a lot of work in community. And that includes a recent lung cancer screening opportunity. So talk to us a little bit about the importance of really getting, and your church reaches how many people in Philadelphia?
We 12,000. It's the largest church in the city. And I say that with humility, because you're right. It's a lot of work for us, but there's a huge responsibility that we feel that we have in this space. And you're right, we've been doing this for a while, and I echo, we're going to keep saying this, we echo what the other panelists are saying. And so just as Stephanie was talking, I thought about it. Sometimes we're not even asked to participate in clinical trials. It's just an assumption that we're just not. And so for years, we've tried to dispel that myth, get involved across the spectrum, if you will, on health concerns, but specifically around cancer for a lot of reasons. It is personal for us. For many of us, it's not a matter of if, it's a matter of when in terms of those conversations. And so creating safe spaces for us is ultra critical. So yeah, we had two noted events just in the last couple of years. But you're mentioning, you referenced the lung cancer screening. And we don't even want to call it that, because when we say lung cancer screening, right away, folk balked or just kind of panicked or react negatively just to the word lung cancer screening. And so we were trying to normalize this screening like any other screening. It's, you know, just like you get your mammogram, your PSA, you really should think about getting a lung health screening. So yes, I'm dressed up a little extra today only because we took a field trip. We had one of our health entities come and present and just talk about who's eligible, who's most at risk, and why. So Stephen, I know this is personal for you, it's personal for me as well. And we expanded the definition. So COPD impacted both my mother and my sister, who are both deceased. So lung health is an issue. But they came, they identified who's most at risk and just tried to normalize the process around the screening. So not only did we do that, but that was at the church. And we said, you know what, we got to take this a step further. So no, we're going to take the field trip. We're going to take a group of our members down and be with them this morning. And so the health provider created a day for us, an Enon day this morning. Pretty cool. And so persons came, trust was already built, trust was already established. We came down and met all the important folks. They took us around just to see what it all looks like and what the experience was going to be. And so I left them there and we're going to pick them back up. But just the day, so I actually got a chance to lay on the machine, the CT machine, just to see it's not scary. It's non-invasive. It's not what we think about, even when persons even talk about, I don't like tight spaces. Well, this was just a donut and you lay on it and you go in. But we helped the members to understand, and Stephen, you said it, all the other cancers combined don't stand up to lung disease. And so it's real for us. We know it. You're right. We are marginalized in some respects, but we're over-indexed in terms of advertising in our communities. We see it. So we've fought with city council. We've gone and sat in on hearings to address that. But for us, it's about trust. And I'm sure that's going to be a common thread throughout this conversation on today. And it's a two-way street. So not only is it about them trusting us to know what's best, and we understand ourselves, we understand our community and what our community needs, but also us trusting them. And so we said, hey, we can't just see you one time. We can't just see you two times. No, you really need to help us understand that you are vested in us. You're engaged in our community, and we're not going to just see you once, but you're going to be with us on this journey. And so we're building momentum. We're super excited. The story is yet to be fully told, but we're off to a wonderful start as it relates to this lung health screening event.
So I just want to check, Stephen, do we have your audio back?
Hopefully.
Yes, we do. Okay. And with that, I'm going to offer you the opportunity to ask a question or, direct the panel a little bit, since unfortunately we had that slight technical difficulty. Where would you like to go next? Who would you like to hear from?
Edith, just really what Edith has to, she's heard some of the other panelists speak, and so really interested to hear her insight.
Yeah, it'll be my pleasure. We at Stand Up to Cancer, began to develop our health equity initiative a few years ago to ensure that cancer clinical trials in all Stand Up to Cancer supported research addressed recruitment and retention of patients from medically underserved communities. I mean, it's been an amazing journey, and I'm so honored to be, the leader of the group, but with a lot of support and collaboration from members of the academic community, business, entertainment industry, advocacy organizations, and biopharma. In the past, we've received funding from Genentech, BMS, Exact Sciences that we've actually utilized to support grants for screening and therapeutic trials. But we clearly know, as we've heard today, that cancer clinical trial participation remains lower for minority groups compared to the relative population levels in the US. And that's why today I'm super excited, first of all, to be here today and also to share news about a new collaboration with Janssen Pharmaceuticals to increase diversity in phase 1 and phase 2 cancer clinical trials. Specifically, Janssen has donated $5 million to support the development of innovative and critically needed approaches to removing barriers to clinical trial participation. Again, addressing, so many of the comments that have been so insightful today. So with this sponsorship, we're going to establish the Diversity in Early Development Clinical Trials program, and will support a research efforts of 4 teams in their selected medically underserved regions. Certainly, I would like to encourage anyone who's interested in improving diversity in clinical trials to visit our website, standuptocancer.org, to learn more about this grant opportunity and apply, because the money is available and we are waiting to get the grant application so that we can support teams. And if I may, in the context of this plan, is the fact that this diversity in early development clinical trials program will encourage collaborations within the selected teams. And these collaborations will include multidisciplinary project teams and federally qualified health centers, clinics and local advocacy organizations serving key medically underserved communities within each team's region. And another aspect, and I'll finish with this statement, and it is that the funded research will integrate social and behavioral determinants of health and community engagement, but it will do this in combination with cancer biology, prevention, and treatment to improve cancer health equity. So again, please look up at our website, standuptocancer.org.
Excellent. So Rick Pazder, you've heard a lot so far. I'm wondering what your thoughts are in regards to the progress that either needs to be made or is being made.
I'd just like to follow up on several issues here. First, Edith's program that looks at really diversity in early clinical trials. And we have been really a strong advocate that diversity in clinical trials begins from the very beginning. And many times people look at, the trial that led to the drug registration, and that's almost too late, okay? Mm-hmm. You really want to have really a diverse population of patients entered in very early clinical trials where you're taking a look at dosing, where you're taking a look at potential very early differences in how different populations of patients may handle drugs, metabolize them, different responses that people have, and perhaps even different diseases within what we call umbrella diseases of lung cancer, et cetera, which are probably composites of many different diseases. So I'm so happy to hear that Stand Up to Cancer is really addressing this issue, because in our guidances that we've written at the FDA, we've really been emphasizing that really one has to take a look at the whole continuum of drug development. So I'm very happy to hear this, because those early signals that can come out of these initial trials can be further explored in subsequent clinical trials, adding more patients, looking prospectively at that patient population in larger trials. So here again, I'm so happy to hear that Stand Up to Cancer is doing this and getting financial support. The other issue that I wanted to bring up is this whole issue of trust. Okay, and we frequently hear of barriers or the cost of doing clinical trials or the cost of medications in the United States. And frequently we look at only cost in terms of finances. And that's very important. Okay, I'm not trying to underestimate that. But one other important cost is the potential lack of trust that patients may have. And that is a result, many times, as has been pointed out in the panel, of not having a diverse population, having patients that look like me or look like that patient that is expressing this. And I just like to remind people that we've learned some important lessons from COVID. Some of our medications are free, okay, the vaccines. Some of our antivirals are free, yet patients are not taking them. And that results from a lack of trust, rather. So one cannot underestimate this. And I think many times the medical community does not address this appropriately. In the United States, when we take a look at drug approvals, we see a ever decreasing number of patients entered from the United States going into clinical trials. So that makes it even more difficult to enroll a diverse population representative of the population of the United States. So we are going to be taking a look, and we've just initiated a new program in the OC called Project Site Selector, of addressing this issue of why and where are clinical trials being done, and how do we increase the representation of clinical trials in the United States? Because if we truly are going to be successful in achieving diversity, we really have to increase the number of our patients that are entered in the United States in these multi-region international trials. So a lot of very important comments were made here, which really resonate with us at the FDA and particularly in the OCE.
It seems to me that, Kareem, you may have mentioned as part of your work, either across the decades or more recently, that you've had some success actually in getting to people in the community who may not have really had an awareness of the importance of clinical trials, and or actually enhancing enrollment for the program which you represent, all of us in precision oncology, precision medicine opportunities. So talk a little bit about how you've been successful.
Thank you for that question, Rhea. And thank you to all the panelists today. Like you said, and I think Stephen mentioned this, the messenger matters as well. When I first started my career in cancer disparities research, I was actually discouraged because I knew that I wanted to focus on African-American men and cancer and health disparities. I was told that African-American men were quote unquote hard to reach population and that I would have difficult time enrolling African-American men in clinical trials. My career has demonstrated quite the opposite. One, because I had community partners and community stakeholders with me since the onset of my career. I often said that my doctoral training and my training was just as much the community teaching me how to do the work that I was doing alongside the scientists that were teaching me how to do the work, and both were valued. And because I had those two amazing teachers, both the community as well as my scientific advisors, I think that impacted my work. So when I went to engage with African-American men about prostate cancer screening programs or lung cancer screening programs or colorectal cancer screening programs, I had very little difficulty engaging those men in clinical trials because A, I was there before I went to ask them to be involved in the study. I was attending their fraternity meetings. I was attending church sessions. I was at the barbershop. I was a constant presence in the communities, talking about the importance of awareness and access. And also when we talk about that, we talk a lot about trust, the lack of trust in communities, but we don't talk a lot about trustworthiness of the healthcare system and addressing those systemic barriers that often prevent populations from getting access to care or access to treatment. I tell many people all the time, if we build it, that doesn't mean they will come, because it's systemic barriers in place that prevent people from coming. When I think about the most pivotal study that really I'm so excited about, the National Lung Cancer Screening Trial that changed the way we do lung cancer screening. Reverend Miles, I'm sorry, I'm going to have a difficult time calling you Leroy today, but Reverend Miles, when I think about the fact that you all had a screening day about lung cancer screening, that's so powerful, because you all are also helping collect data, not just research data, but clinical data. Because when those studies are conducted and when how we determine what populations are eligible for lung cancer screening, what are those screening criteria? Unfortunately, when those studies were conducted, populations that look like us were not included in that. So when I took those recommendations for lung cancer screening back to the community health center that I was working for at the time, the Federally Qualified Health Center, they looked at me and said, Kareem, these screening guidelines don't capture the smoking history of the patients we serve. They don't capture the family history. They don't capture the environment. So it is so important that we think about place matters as well. I said the messenger matters, but place matters. And Edith, you mentioned this. You mentioned Federally Qualified Health Centers and community health centers. I'm so excited to see Stand Up to Cancer, to include them in your outreach in terms of including those populations in cancer. In the All of Us research program, we have been able to reach something unprecedented in terms of genomic research. To date, we are proud to note that we have enrolled over 500,000 participants who have started their journey with us. Of those 500,000 participants who have started their journey for us to eventually get to 1 million participants, over 50% are racial and ethnic minorities, with 20% being African American. That's unprecedented. And the reason we have those unprecedented numbers is because of community partnerships and community engagement. I'll stop with Reverend Miles. We actually kicked off the enrollment of the All of Us research program in New York at Abyssinia Baptist Church. So that meant that we had the trust of that faith leader, the trust of the First Lady, Sister Butts, and they're leading us and opening that congregation to us. And by that faith community opening up that congregation to us, that sent a message to those parishioners and those community members that we were going to be a trusted partner and that their voice was valued in this journey. So I can't stress the importance of the messenger matters, as Stephen said, place matters, and trust matters.
Now, Kareem, you hit the nail on the head. It's about, you're right, leadership and us willing to stand in that space and have a level of transparency. Hey, we're human as well. We're going through some of the same things. And for us, along the line of colon cancer screening, it really was the passing of the actor Chadwick Boseman. When he passed, and we have a couple of group threads that were on just the fellas, we reacted and we took it personally and said, man, if the Black Panther who has abs, can get colon cancer, we don't have a shot. And that's when we actually stepped up and called some of our relationships and created a screening that went very well. It was pretty well documented, but it's always personal for us. And we did it at the church as we do many of our screenings. We know that people will come to us first before they go other places. And so if it begins at the church, or we'll take it a step further, if it happens on a Sunday morning for us, that just speaks to just how important it is. So yeah, I agree with everything that you shared. And we'll even talk about how we can get that number of participants up for you.
I do have a question.
Sure, go ahead.
Great. So again, I appreciate the conversation related to building, cultivating trust and maintaining trust within the communities. On the other side of that, what are your thoughts on, and anyone can answer, of course, what are your thoughts on addressing some of the implicit biases that some of the healthcare providers or clinicians may have when in terms of navigating these spaces where they may not know how to communicate effectively to a group that they may not have been raised around, but they know that there are diseases here, there are cancers here. How do we encourage someone to look inside to address some of the biases that they may carry?
Perhaps I could make a few comments on this, because what we did at Stand Up to Cancer is actually that we changed the guidelines that investigators use to apply for grants. We actually included wording stating that the anticipated projection for accrual should meet the percentage of patients in diverse populations that are expected to suffer from the disease. So we made that integral to any grant. And so that is a way to change some people's minds. But in addition to that, we've done a lot of multiple cancer screening, prevention, and clinical trial awareness campaigns, and public service announcements to address not only the academic community but also the local populations, encouraging Black and Hispanic participation in routine cancer screenings and cancer clinical trials. So, we think that by engaging the community advocacy groups with academic centers, it's one of the ways to really change the old ways.
To me, it sounds cliche, but it requires empathy. And I think oftentimes when providers, when there's congruence between a patient and a provider of just that human congruence, regardless of race or whatever, but when I look at a patient and can tell a patient, I'm treating you the same way that I would treat my aunt who has lung cancer. That empathy is important. That empathy builds that trust. And to create and build more empathy, it requires a diverse healthcare population or diverse healthcare providers. Those providers don't have to be physicians, they can be MAs. They just need to be individuals that within the healthcare space can impart just basic things, the language. Oftentimes when I communicate, I have to use two types of vernaculars, just the medical sort of information or the medical jargon, but at the same time, I have to bring it to a level that patients understand. And so I saw a patient today earlier who has metastatic breast cancer, who now has fluid in her chest. And so I'm explaining to her a pleural effusion, trying to get her to, her end destination of trying to go to Costa Rica, and just really trying to walk that journey with her to really get through it. And oftentimes, especially with my cancer patients, these visits last longer than the 30-minute, block of time that I'm scheduled. And so it really requires a change within the system to offer that time. I think Stephanie mentioned, as far as there's a lot of external help, the other things that patients need more than just medicine. They need that humanistic aspect to be able to just sit and talk with their provider to let them know that, hey, look, doc, I got stage 4 cancer. You just told me I had stage 4 cancer, but I really want to go to Costa Rica. What is going to be the best way for me to enjoy my life? Because at the end of the day, I can treat cancer with a variety of different treatments. But if it doesn't offer my patient the quality of life that they and their family want, I got to ask myself, did I really help that patient out? So to answer the question, I think it's about empathy, and how do we create more empathy within healthcare? And it's a difficult task, but I think it's really trying to, as Edith's point, try to have the healthcare population or the healthcare providers reflect the community that they're treating.
That's great. If I may, just one more thing, I just thought about Stephen's comment here. And, we're talking quite a bit about lung cancer, and deservingly so. Well, one of the areas that I think it's important to address is actually appropriate tumor testing for molecular markers that may be predictive of efficacy of novel compounds, because that is an area that has changed so much in lung cancer over the last 10 years. And still many patients, I don't think, are having their tumors properly analyzed for the 8 or 9 different biomarkers that now we can use to optimize the recommendation for therapy. And that applies to all populations, including Black and Hispanic communities.
I would like to say something on that. That Edith and Stephen both said, it's about spending the time with me. I'm the patient, and trying to get to know what I need and offer me those things and explain them. You can't offer me genomic testing or tumor marker testing and then leave the room, because, my head has gone in 54 different directions just from that comment. And you need to sit down and tell me. And if I understand that you have a certain amount of time that you can come and talk to me, then have the nurse to talk to me. Schedule me a nurse visit or something where it can be the continuity of care, can be offered to me from the comments that you made in your visit to explain these things to me. And don't take it for granted just because I'm Black, that you're going to come in there and you've already have these preconceived notions already. First of all, that I'm going to drop out of a clinical trial if I enter one, or I'm not going to finish my treatment plan because, and that strong Black woman thing, I am strong, but there are days that I just can't. And I just wish that people would get that out of their mindset as well. And just, I'm not going to say really dumb it down for me, but to explain it to me so I can understand. And I can always say 95% of the patients that I've talked to and met during this journey is quality of care. Quality of care outweighs quantity. And you can make me live forever on a chemo drug, but if I'm sitting in the bathroom on the toilet with my head in a trash can, that's not a quality of life. So I need to have the quality of life with my treatment. Give me the best that there is. Offer me the genomic testing. Let me make those decisions. As Stephen said, talking to the patient about, make me well enough so I can go to Costa Rica. Ask her if she needs a partner. I'll go. That's part of the quality of life. So talk to me, ask me, include me in that plan of care as well.
Rhea, if I may, Callie, I love your question about the patient included in that. And I was trained also in community-based participatory research, CBPR. And we don't talk about CBPR principles enough in clinical trials. We talk about CBPR when we think about sociology research and other areas, but we need to bring those similar principles to clinical trials. And one of my patient advocates, Kimberly Richardson, who started the Black Cancer Collaborative, reminds me constantly about how do we equitably include a patient as a partner in research. If I used to email Kimberly and ask her to be a part of a research study and that research question was already baked, she would say, Kareem, I'm going to join you, but you invited me a little too late, brother. You should have called me early on when you were developing that research question. And having patients at the table to help you develop those research questions actually improves the science, because you're developing a research question that is responsive to the needs of the patients that we serve that eventually may become participants. And also, and again, I'm really proud of our program because we have a partnership where we actually work with the Meharry Vanderbilt Alliance led by Dr. Consuelo Wilkins through having a participant engagement core, where participants in our program are actually part of our governance. They'll help and determine our IRB approval process. They'll help and determine how we disseminate our information. They're helping us even determine how we message our program. So having participants as partners, no matter where you are through the research program, can also address those issues that you sometimes see of lack of trust and lack of access. And I can't talk enough about the importance of access. Edith, you mentioned molecular targeted testing. When my mother was diagnosed with lung cancer, you shouldn't have to have a son that does cancer disparities research for you to have to tell that clinical team to stop. Don't start that treatment until you've tested her tumor. But too often, patients in community settings, they don't know this. And I hope that we're moving to the place in medicine where you should not have to get your care at a premier academic medical institution that can test your tumor, but we can have those same issues, same access things in our community hospitals and our safety net hospitals. So I'm hoping that, Callie, the AACR, the recommendation that you all just put out, which is amazing, by the way, can really help drive the way around these recommendations.
Absolutely. And thank you so much for that. And a consistent theme that I hear when I attend all of these different types of meetings is that, nothing about us without us. And so recognizing not only someone's humanity, but recognizing that I do need to be involved in that conversation sooner rather than later. And then something else that I'm reminded of too is I was, instrumental in working on the workforce chapter within our Cancer Health Disparities Progress Report, is that being intentional about diversity, being intentional about inclusion. Because a lot more times than not, if we don't have a voice at the table where decisions are being made, but we're still being impacted by those decisions, that doesn't facilitate trust. That doesn't cultivate that doesn't really cultivate respect in certain regards. And so again, this is an amazing conversation, recognizing the humanity of people who have been historically marginalized.
So can we broaden a little bit in regards to that workforce aspect? Because let's face it, there needs to be a continuous pipeline of really dedicated, caring people to make a difference. And I know, obviously, at OCE, Dr. Pazder, it's a big part of what's baked into the work that we do. But are you seeing that across the, oncology, ecosystem, that there is this push to have a very, very diverse workforce working on all aspects of cancer research? There is from my studies, there is a push, but again, if the support isn't there, throughout your training, I prefer pathways over pipeline, but if I'm not supported as I navigate my pathway to becoming a successful, oncologist or cancer researcher, then it'd be very hard to stay on those paths. It'd be hard to retain me to then see someone who can benefit from my skill set. And so there is a push, but from my understanding, being intentional about what that push looks like, because it's not just a matter of getting as many bodies as possible, but it's about, supporting and celebrating the people that are there.
I wholeheartedly agree. I mean, we're seeing that now in the training pathways of residents, and, going through their medical careers and even after training. And so it's very important that all institutions have, that intentional focus for diversity. And to echo some of the sentiments that Richard and Kareem mentioned in regards to messaging, I think that one of the things that came out in regards to COVID-19 was this whole notion of individuals not wanting to be guinea pigs. And when you talk to individuals about clinical trials, oftentimes people say, I don't want to be guinea pigs. And I think it creates the opportunity to message, that participation differently. And I like what Kareem's organization has done, because in a sense, these patients are pioneers. I mean, they're being pioneers in a new treatment or a new treatment paradigm that can affect a variety of people. And unless those pioneers step forward and volunteer and participate, we won't be able to know the benefits of some of these medications. And so I think that trying to educate patients as to the process of clinical trials, as well as addressing those heart-to-heart concerns that people have and speaking to them in a vernacular, in a way that they understand. And when someone says, I don't want to be a guinea pig, understanding that that's, a real sentiment, and almost reframing that from the standpoint of they're boldly going where no other person has possibly gone before. And so we need those pioneers to kind of move the needle forward. And that's, liken it to the moonshot. We would have never reached the moon if individuals weren't pioneers to really take that leap of faith and to go up there. So it is a courageous act to participate in a clinical trial. And I think that those individuals, like Kareem has mentioned, needs to be brought along that path and not only recognized, but be made to feel a part of the journey that they're taking, of the discovery that they're helping the medical community take.
Stephen, I agree. And I think for us, especially as a church, as a ministry, we're really trying to create an ethos, a climate that says it is necessary. It is your reasonable service to participate. And I know that may sound foreign, but that's where we've been, and we've been in that space for years for obvious reasons. Again, like we said, in some cases with certain disease states, it's not a matter of if, it is a matter of when. And yeah, we don't want others to bleed where we've bled, figuratively. And so creating these conversations, having the experts come and talk to us using that same level of vernacular that we can understand it, we can get it, and then be able to distill it to our membership is real important and very necessary. So that being said, we're now open and we're participating. We have, we're partnering with the researchers and having persons come and participate in 30-year studies and things that have been unheard of simply because we created an environment. So just like we created a day, a lung health screening day, we've also created a day where persons who are over the clinical trials would come, talk to us, and not have to feel rushed. So really spend that time after service talking to persons who are candidates for the trials, making sure that all of their questions are answered. And this is happening in our Family Life Center. This is happening on our church campus. So again, we're eliminating those barriers. We're already here. Now you're coming to us and you're spending that time with us. And so as a result, the outcomes have been significant. Again, persons who do the trials will come in and they're amazed with the level of participation. But the reality is we've created a climate where we really want our membership to own their health, to actively engage and advocate for themselves. So we're I hate to say it like this, but we're training our membership to be advocates for themselves and understand this is your reasonable service. If you're not doing this for yourself, you're doing this for the community, our community, or for the loved ones in your life. So
that's perfectly fine to say. I know you were trying not to brag in some sense, but some bragging is important, particularly if it's true and it helps outcomes. So we do appreciate that you're trying to be a little bit humble, but the work that you've done in the community and the fact that you have, even during COVID, you all were in the parking lot handing out colorectal take-home kits for people to utilize and then send in the results. And that made a difference in the lives of many people in which there were some issues detected and services were provided. So that medical care may not have existed prior to the church taking up the activity to say, this is important enough for us to do on a cold, snowy day in Philadelphia in the parking lot.
Yeah. And being creative and Kelly, you asked the question, and one of the things that we thought was really important that we felt heard as participants. So that event was, and I actually shared it with the team so they can see it, the study that happened. But we had a DJ, we had all kind of stuff that we thought was important on that day. It's an outside event, it's a drive-by event, but these are the components that we bring to ensure the success of. So yeah, it was the FIT test, the colorectal cancer screening, which we know usually has a low rate of return. But we wrapped it around, again, the passing of Chadwick Bosewick. We thought that, this was an opportunity. We seized it, and folk got the test. And in some cases on the same day, well, within hours, they took the test home and they came back with a completed test. It is what it is. And we celebrated that, we kind of clapped and made a big deal when somebody brought a test back, but we had an over 80% rate of return on a test that we know historically is maybe 3, 5, 7% maybe on a good day. And it happened during the pandemic. So we weren't inside, we were outside. We provided this event. It went extremely well. And then when you pull around the corner, we had our nurses and the Black nurse sorority doing blood pressure screenings. We figured, hey, you're out here, we might as well catch you on the back end, and partnering with the Heart Association. If you tested high and you didn't realize that you had it, and you can take a kit home and we'll let you hold it for 30 days. So we created a library card type scenario. So when we're addressing one issue, we found that if you have this multi-tiered approach, it does increase the outcomes for sure. So thanks for bringing that up.
Rick, I don't know if maybe you were on.
Yeah, one of the things that I wanted to mention is that we should not forget that the care when somebody goes on a clinical trial really is the best care too. And many times we forget to emphasize that to patients, that there's extra sets of eyes on people, so to speak. There's IRBs that review the protocols. There's experts that have given their opinions on far as the therapies that are being given on the protocol, how doses are modified. There's research nurses that are involved that see the patients. So patients actually get better care. So instead of this kind of negativism that people are guinea pigs, we probably should be advocating that you're actually going to be getting better care by going on the clinical trial, because there are these extra set of eyes, both on the assigned treatment, of what that treatment will be, how it will be administered, and even during your course of therapy, there's extra people that are involved for you to communicate with. And there's been several studies that have been done that patients that are on clinical trials actually live longer than those that are not. And there's a variety of other reasons that could explain that. But I think that it is important for people to realize that there are some positive advantages, and those include not only getting newer medications, but also better care with more people involved too. And I think that's one of the things that many times we neglect to emphasize to people when we're talking about clinical trials to them.
The upside.
I love that you brought up some of the benefits of clinical trials. Sometimes we are limited in how we can talk about the benefits of clinical trials because of clinical equipoise and these other big terms. We can't say, offer a benefit, but we can explain them in a way that when I told my family that I was changing my healthcare career trajectory to go into research, they used that term guinea pig. They said, so my family's from the South. And so, my dad had memories of the United States Public Health Service study that happened in Tuskegee, Alabama. We inappropriately called that study the Tuskegee experiment, by the way. I would encourage you not to call it the Tuskegee experiment. Tuskegee did not ask for that study, and calling it the Tuskegee experiment puts a negative connotation around that city. So I encourage people to use the long name of that. But my family members had memory of that. And so it was really important. For example, when we launched the All of Us research program, prior to launching it in the Illinois Precision Medicine Consortium, we actually had a panel of over 500 community members attend, where we had 4 generations of the family members of Henrietta Lacks. So imagine the power of having the daughter-in-law, Jerry Lacks, the granddaughter of Henrietta Lacks, the great-granddaughter of Henrietta Lacks on a panel saying, we feel that our grandmothers, our great-grandmothers, our mother-in-law's legacy is for inclusion and for equity, not for us to not be at the table, but for us to be at the table. Veronica Robinson, who's now become a friend, can have way more of an impact in getting people aware and engaged in clinical trials than I ever could, because she can talk about the experience of her great-grandmother, Ms. Henrietta Lacks, and that story. But I also want to speak to something that Reverend Miles talked about earlier, and that's the power that you can, when community members are given a space to, I don't even like to use the word empower, but to self-actualize, because our community members already have the resources. They already have the wisdom. Sometimes they just need more resources to elevate that wisdom. I was doing a project with African-American men around engaging them as citizen scientists right after the untimely death of Chadwick Boseman, to train and engage barbers, fraternity leaders, and other lay community leaders, all African-American men, the importance of participating in clinical trials around colorectal cancer screening. During one of the talks, we had Dr. John Stewart, a surgeon, now the cancer center director at LSU, talking about the importance of cancer screening. And we also had Dr. Keith Naylor, an African-American gastroenterologist, talking to these Black men about screening. Dr. Naylor and Dr. Stewart told one of the citizen scientists about the new age guidelines for colorectal cancer screening. One of those citizen scientists doing this training called his primary care provider on the Zoom call and said, you told me I could wait till I was 50 to get screened. The American Cancer Society just changed the screening guidelines. I need to get my screening. He's going back and forth with his primary care provider. Long story short, he wasn't 50, went in to get screened and had polyps. And so he came back and said, imagine had I waited Imagine if I had not been given the information to advocate for my own screening, what could have happened? And so and then he went out and told other family members and told other people. Because of that one citizen scientist that I had, we had 4 of our friends to go get signed up for colonoscopy. I've been preaching and teaching colonoscopies for a long time, but it took another colleague who's not a scientist to actually talk about it through his lived experience. So I can't stress the importance of community advocacy enough. And for those of us to make sure that our community members have resources to be at the table with us as equitable partners as well.
That is an excellent point. I love that term, citizen scientist, because, in reality, we're all responsible for our own health, but we do need some help, right? It doesn't just come automatically. It doesn't drop from the sky, all of this important information. And as we can tell, once you engage people and inspire them to learn more, to become more educated about opportunities, about clinical trials, there are different types of clinical trials. People don't even know family history issues, which, by the way, brings me to the tagline for this particular initiative, which is engaging the generations. So let's spend just a couple of minutes talking about that. And then I'm going to ask each of the panelists to give us your take home, your action items, but why the importance of discussing family history, particularly if you are not a scientist.
And before we go there, Rhea, I did want to stress why I did citizen scientists. I do encourage the use of the term community scientists because it's a much broader term that includes other community members. And so while the group of Black men that I was working with loved and embraced the term citizen scientists, I also encourage the term community scientists as well.
Okay, that gives us a little bit more breath. We can relax a little bit more. It's not quite as pointed, but the importance of family either way. And whether that is actual biological family, because let's face it, in a lot of communities, your auntie is not necessarily your mother's sister. So, why is that level of conversation important in community when we're talking about cancer awareness? I did not think it would go silent there. Go ahead, Edith.
Perhaps I can start. It's amazing to me. Sometimes I've spent time with patients discussing clinical trials and all the options that we have. And then they go and read a newspaper and they may be swayed by what's in the newspaper related to what their appropriate therapy should be. So I'm saying this because we're influenced by our environment. And we're certainly influenced by the familial environment. We have issues. We think about the issues and then we talk to our friends and family. So it's talk about inclusiveness in this world. We want progress to continue to be made, and family, it's really important as progress goes on that path.
But we talked also about trust initially, and I think there's no more trust than one could have is amongst basically your family members, so to speak. So if you really want to have a discussion, who would you really turn to first? And most people would turn toward their family, obviously, because they will have their best interest in mind. And there's no ulterior motive that a family member necessarily would have in giving advice and recommendations and love, basically, to that person.
I agree with that. And I also reflect back on Kareem's story and how he transitioned into research. And even though you would like to be the most trusted member in your family, but there are instances where either your age, because there are times when like my grandmother passed away from breast cancer. And so there was no discussion about that at all. And so it's very challenging to be, a younger member of a family who's now moving to research. And now you're like that young one who think you know everything. And so hopefully, the trust can be, hopefully someone can talk to you and your family about building that trust. But the importance of learning how to shift the narrative from something negative, like you aren't a guinea pig. We should have these conversations. This isn't something you should carry on your own. Like there are times it's important to be, if you can't be your own advocate, at least someone else in your family that you love and can trust can be that advocate, but that requires you to have these difficult conversations that typically people shy away from.
Exactly. And that's where I say the younger generation has a little bit more on their shoulders about educating the older generation. And it is, if you're young, you've heard all these things, working in the ER, I would see these older women come in that would have metastatic breast cancer or something, to the point to where their breast was gone, but they didn't want to bother their children with the information. They didn't want to, have the family to worry about them and that kind of thing. But we need to, as everyone has said here, break down those in our own home. We got to start there before we can take it to the community. So we need to have these open conversations, candid conversations, at our house. First and foremost, I'm the first breast cancer patient I know in my family. My mom had lung cancer and I had a brother that had ALL. But it is just, hard to, I don't want my daughter to go through this, and I definitely don't want my son to have breast cancer, but these are hard conversations to have when you have a family member that doesn't want to listen or doesn't, as you said, the know-it-all, you think you know it all. So I stress to make sure that you start at home and start with yourself, because I'm one of those women that I thought I did everything right to prevent breast cancer. But, stuff happens.
That's not necessarily how it works. Exactly.
Yeah. And you have to tell people that it's not anything that you did, or carrying your cell phone in your bra, how many of us have done that? I was a flight nurse, stick it right down there and keep going. But, that didn't cause my breast cancer. So, you have to dispel myth along with giving truly vetted, good information.
Well, this is a great panel to listen
to. Drinking, juice from the kangaroo from Egypt ain't going to make it go away.
Okay, and that I don't know anything about, so I won't speak on it. However, I will do a quick round robin of our panelists as we wind down this session. Let's see. I'll start with you, Leroy. I managed to get it out without saying Reverend this time, but it's still in there. So your final thoughts, takeaway, things that you think are important for people to be aware of during National Black Family Cancer Awareness Week through the 22nd of next. Yeah, go.
Absolutely. Having the conversation, and then for us being creative. So, we're going to continue to be creative, press the narrative. So, today's event was today's event. On yesterday, we had a health event for our seniors. And on Saturday, we're going to have a cancer walk, and it's called the Colorful Walk. So we'll have survivors and relatives come out and they'll wear colors based on the type of cancer that has either impacted them or has affected them. And it's going to be celebratory because we're celebrating those survivors. We're offering a message of hope, but we're being creative. This is the first time we're doing it, and it's not a big thing where it's a big fundraiser. It's just going to be our church membership come out. We'll have a word of prayer. We'll have some conversation. The DJ, of course, will be there. We kind of like music. And then so we're going to have a mile walk around the campus. And then for those who can't walk that distance, just a short up the block and back down. So we're encouraging folks to stay creative in this context. We're still not out of the pandemic, as we're clear of. And so being creative in the space that we're in yields significant results.
Thank you for using #BlackFamCan. Kelly.
Yes, so a couple of things. One, get screened. Cancer screens are incredibly important. Two, become your own best advocate. And the third point, and I've touched on this a little bit, but I just want to remind people to engage their local and state representatives about the importance of supporting cancer research. And I'll drop a link in the chat soon about our upcoming Rally for Medical Research, because again, a lot of times when I'm joining these calls, I'm usually more times than not the only Black woman on the call. Mm-hmm. And there are so many voices that need to be heard, especially when you need to advocate, not just for yourself, your local needs, but also the needs of others.
Yeah, thank you. And Stephanie, yours is one of those voices. And I know that we've, leaned on you a lot, but, final comments?
As she said, get screened. Please get screened regarding whether it's colon, prostate, or breast. Make yourself be heard, not in the angry Black woman rim, but as a Black educated man or woman. Make sure that you're being heard. And if you're not being heard by that provider, search out somebody else. You make yourself be heard, whether it's by him or the next one down the road or the next one down the road, to get your problem resolved. And to the healthcare providers out there, ask me. about clinical trials, ask me.
Yes, ma'am. Thank you. Stephen.
So thank you for this. This has been great. First and foremost, cancer care is communal. It takes a village. And so with that, we need to encourage the next generation of providers to really look at medicine as a career in any way, shape, or form. So check out the book, The Heart of the Hero, on Amazon. Go to www.livechair.co to look at a way that a community health organization is really trying to impact communities of color in decreasing healthcare disparities. As it was mentioned, get screened. So if you're 50 to 80 years of age, if you smoke a pack of cigarettes for 20 years or more, and if it's been more than 15 years since you've been smoking, or less than 15 years since you've last smoked a cigarette, go ahead, get screened like Reverend Miles did with his organization, with his congregation, get screened with a CT scan. And again, community care is, cancer care is communal. So if you know of a family friend or a loved one that has cancer, go with them to the doctor visit. It's amazing how much information gets missed by the patient. Approximately 50% of all information that's communicated at a patient-physician interaction or visit for cancer care is missed. And so it's important to have that other person in the room to be the ears of the provider to help them get all the information that is necessary. And definitely support the FDA and the ban on mentholated cigarettes. So thank you.
Thank you. And the commissioner thanks you as well. Edith.
Yeah, participating at meetings like today just makes me think, my gosh, the future is bright. Things are going to get better because there's such a committed group of smart individuals, not only thinking about the problems, but finding the solutions to these problems. And I just want to call specifically that my appreciation to be part of what we're doing together, and also to Stephanie, a word to Stephanie, because having a diagnosis of breast cancer can affect any person in a significant way, particularly being diagnosed with metastatic disease. And as I think about this, things are getting better. The work of you, it will impact the lives of thousands. And I just wanted one quick scenario, which is, I have one of my patients, and I can make this public. Her name is Donna Deegan, who was diagnosed actually with metastatic breast cancer back in 1997. And, we started the 26.2 with Donna, which is also called the Breast Cancer Marathon, breastcancermarathon.com. We had the first event in 1998. She's alive, doing well, and healthy. And this is after metastatic breast cancer to lungs. So I just want to offer this, the tangible truth that if we continue doing research in alignment with the patient's needs, the future, it's bright. So best to you.
Thank you for that. That is important. The tangible truth, Kareem, I feel like you live there.
I do, and I'm so thankful for that. I'm really excited and just full with the discussion today. And I want to encourage people to visit joinallofus.org. Again, that's joinallofus.org to find out more about the NIH All of Us research program. It really is an innovative approach to ensuring inclusivity in terms of diversity, equity, and inclusion in clinical trials. And from our research program, it also gives data for other researchers to be able to ask questions that they've never been able to ask before, because our data set does truly reflect the populations that carry the greatest burden of disease. And I can't stress enough, I have to end with a quote from another community advocate, Candace Henley, who had founded Blue Hat Foundation after she was diagnosed with colorectal cancer. Candace said that family secrets kills families. So really, really spread this conversation of having open and honest dialogue. I throw around to my family that I talk to my therapist. I try to make it like talking to my therapist is just like talking to my pastor, and I talk to both. And I encourage them to do the same. And my pastor encourages them to do the same as well. So I can't advocate enough for the importance of having safe and trusted conversations with family members.
You live it, walk it, and talk it, sir. Thank you. Rick Pazder, final comments, sir.
Oh, I'd just like to thank everybody for a marvelous conversation. I can't believe that an hour and a half went by so quickly. And I just like to reiterate our commitment to diversity in clinical trials and diversity in medicine in general. A project community that RIA heads is really an effort obviously to get out into areas that the FDA has not been visible. Most of our activities, unfortunately, revolve around the Washington area, and we should never forget that there's a big country out there outside of the Eastern Seaboard, so to speak. So that's part of our commitment to getting out, to hearing diverse voices. But in addition to that, we have a whole project called Project Equity, which is aimed at having companies develop plans to look at equity in clinical trials. And again, starting from the very earliest clinical trials to those trials that lead to drug approval, to those trials that are done even after drug approval. And in addition, we haven't talked about this project, and that's Project Summer Scholar Students, where we actually are trying to incorporate what we do here in the FDA and bring that out to students that come from inner city areas so they can understand and encourage careers in healthcare professions. And I think that that is vitally important as we move forward in this. So I just want to emphasize the commitment that the OCE has in really the whole issue of diversity and bringing it back to the family. I just like to emphasize and just leave you with this last statement. Nobody loves you like your family. So please hold them close to you. And I think that that's the most important thing that we have as we move forward in our discussions here.
I just want to thank you all for your truly insightful comments, for your time, your attention, your commitment to community. What you do is extraordinarily important, and that's amplified by all the people who are attending this particular public panel discussion, mainly because all of us can have a role. All of us can make a difference. All of us can speak to someone, whether it's about trust issues or communicating effectively or going with a patient to see their oncologist. We can all do something that helps the rest of humanity work through the issues that we all face when it comes to cancer awareness. And so I thank you. I encourage you to use the hashtag BlackFamCan, because this is, in fact, National Black Family Cancer Awareness Week. This is day one, but there are 6 other days to go, and we will look on social media for your various, I'll put it this way, events and activities, because I know there's a broad spectrum of things that are going on, from other panel discussions to walks at neighborhood churches. And so for everything each and all of you are doing, thank you very much. And do talk to someone about National Black Family Cancer Awareness. Thank you very much. We appreciate your time today. Bye-bye.